Are you there?
I am. Can you hear me?
I can. Okay, we can get started.
Wonderful. Thank you, everyone, for your patience. Good afternoon, and welcome. Thank you for joining us for Emergency Preparedness, Provider Readiness. Today's webinar is brought to you by the CMS, Consortium for Quality Improvement in Survey and Certification Operations, and the CMS Center for Clinical Standards and Quality, Quality, Safety, and Oversight Group. The webinar is divided into 4 sections: the 1135 Waiver Process, the Emergency Preparedness Final Rule, Observations and Lessons Learned from Recent Events, and Resources. Each of the 4 sections will be shared by a member of the team. Presenters presenting today will be Karen Fuller, Cece Blondow, Julio Griffin, Lauren Reinerston, Nancy Miller, and Adrienne Saunders. At the conclusion of this presentation, you will be able to demonstrate knowledge of the 1135 Waiver Process, understanding of the Emergency Preparedness Final Rule, awareness of emergency challenges from recent events, and an understanding of available resources. If you have questions, please enter them in the chat box. At the conclusion of the webinar, if time permits, we will answer a small number of questions received. For questions not addressed during the webinar, please submit them via the evaluation link that will be shown at the end of today's presentation. General questions can be sent to the email address on the screen, scgemergencyprep@cms.hhs.gov. The information contained in this presentation is a tool to assist you as a provider or supplier in your emergency preparedness efforts. This is not a legal document. Official provisions of the Medicare program are contained in the applicable laws, regulations, and rulings. Karen Fuller will now share with you the 1135 process. Karen?
The Social Security Act, Section 1135, authorizes Medicare, Medicaid, state children's health insurance, and health and human social services programs to temporarily modify or waive certain Medicare, Medicaid, CHIP, and HIPAA requirements. The 1135 waiver process is to ensure that there are sufficient healthcare services are available to meet the needs of the individuals enrolled in SSA programs and where an emergency is experienced. As the above slide shows, or the slide shows on your screen, for a waiver to be considered, a prior emergency declaration is required. Section 1135 waivers require both a declaration of national emergency or the Stafford Act and a public health emergency declaration by the HHS Secretary under Section 319 of the Public Health Service Act. A state declaration of emergency does not qualify under these requirements. However, it is usually relevant to the HHS Secretary's determination. I want to repeat that. A state declaration alone does not qualify under these requirements. Next slide. What is the purpose of an 1135 waiver? The purpose of an 1135 waiver is to ensure sufficient healthcare items and services are available to meet the needs of Medicare, Medicaid, and CHIP beneficiaries, and to allow healthcare providers who in good faith provide services to be reimbursed for them and not subjected to sanctions for noncompliance, absent, of course, any fraud or abuse. Let's discuss some common areas that providers need to know and have had questions about. Next slide, please. What is the scope of an 1135 waiver? 1135 waivers focus on federal requirements only, not state licensure. During an event, a determination is made regarding the scope and the severity of the event with specific focus on healthcare infrastructure. Questions are asked such as, are there unmet needs for healthcare providers? Can these unmet needs be resolved within our current regulatory authority? What is the purpose of an 1135? The purpose is to allow reimbursement during an emergency or disaster, even if providers cannot comply with certain requirements that would, under normal circumstances, bar Medicare, Medicaid, or CHIP payment. How long are 1135 waivers good for? The waiver's duration and no later than the termination of the emergency period, or 60 days from the date the waiver or modification is first published, unless the Secretary of HHS extends the waiver by notice for additional periods of up to 60 days, up to the end of the emergency period. In addition, non-pandemic waivers of EMTALA sanctions are subject to different requirements. Their duration in EMTALA is generally limited to a 72-hour period, beginning with the implementation of a hospital disaster protocol. However, when a public health emergency involves a pandemic, infectious disease, waivers of EMTALA sanctions can be extended through the duration of the public health emergency. Next slide, please. It is important to note what waivers do not, and this is often a very a point of confusion. So waivers are not grants, they're not financial assistance. They do not allow reimbursement for any services otherwise not covered. They do not allow individuals to be eligible for Medicare who otherwise would not be eligible. They should not impact any response decisions such as evacuations. This is a very important point I want to stress, that you need to take the actions to care for your patients, your residents, and yourself and your staff to ensure their safety. We can, CMS can, and we have resolved 1135 issues when it is safe to do so. In other words, if you're evacuating, evacuate. We can, within the next day, work on the waiver. But take care of yourself, your staff, and your patients. It's very important. Waivers do not last forever. Experience has shown us that air scrubs get finished, repairs are made, facilities are cleared for repopulation, and they reopen. As such, the appropriateness of an 1135 waiver fades as time goes on. Next slide, please. What are some of the examples of an 1135 waiver authority? There is the ability to waive the conditions of participation or conditions of coverage, depending on your type of provider or supplier. For instance, the critical access hospital 25-bed limit and the average patient stays of less than 94-hour requirements for pause can be waived. Another example is the waiving of the 3-day prior hospitalization requirement for SNF patients. Other possible waiver categories that we have had include licensure for physicians or others to provide services in the affected state or states, the Emergency Medical Treatment and Labor Act, EMTALA. For instance, a request could be to set up alternate screening locations, and we have published guidelines on that, which you'll find out about when we refer to the resources later on in the presentation. Stark self-referral sanctions, Medicare Advantage, HMO, out-of-network provider provisions, and based on OCR determinations, HIPAA rules. Experience in the West has shown many questions about movement of SNF evacuated residents. For example, discharge versus admission to another facility and the related timelines. Movement to a related facility that is under a denial of payment for new admissions, which could be waived, and MDS requirements. Those are some of the most frequently questions that we get in the West based on our fires, floods, and potential mudslides. All these requests requires dialogue with both your licensure and survey and state agency and the applicable survey and certification regional office. How do you obtain coverage under a waiver? This is a very common question. Once the 1135 waiver has been authorized, service provider requirements are not automatically waived or modified. CMS implements the waiver by determining on a case-by-case basis whether or the extent to which sufficient grounds exist for waiving requirements with respect to a particular provider, a group, or class of providers, or a geographic area. The 1135 waiver review process. Providers can submit requests to operate under the waiver authority to the regional CMS offices. The listing is given in a later slide, and or through your survey state agencies. Should you find that your facility is impacted by a disaster or any other emergent event and determine that you may need to request a waiver, I would like to emphasize that there is not a standardized waiver application form or template that is required. That's the most common question we get. There is no standardized waiver application form or template that is required. However, CMS requests that an entity provide basic information about the provider, contact information, and a brief explanation of what the waiver is needed. The slide shown to you outlines some of the factors involved in CMS's review of a waiver request from a declared area with an actual need. Let us quickly review the slide. The slide basically says CMS is looking, are you requesting something and are you within the defined emergency area? Is there an actual need? This is very important. There must be an actual need. We do not do hypotheticals or preparatory waivers. There must be a need. What is the expected duration? For example, is the floodwaters here, but they're doing this, but you think you can clean up? Can this be resolved within the current regulations? Very often we're able to make resolution by using state licensure flexibilities. Will regulatory relief actually address what's the need? And should we consider individual or a blanket waiver? The blanket waivers are more common when there's a huge event and geographic area impacted, or sometimes in the pandemic infectious disease. Next slide. There are many people and facilities and partners involved in the waiver review inputs. CMS does not unilaterally make these decisions. As you can see, it's a collaborative effort among the partners listed. There's the facility, CMS working with the facility, the state emergency and licensure staff, the HHS regional emergency ASPR coordinators, and provider associations. Next slide. Questions have arisen regarding the relation of the final EP rule and the 1135 waivers. To be compliant with the requirement under the Emergency Preparedness Final Rule, which will be discussed next by Cece, you'll need to have a policy and procedure for addressing your facility's awareness of the 1135 waiver process. There is no specific form or document template. Some elements that could be considered and reflected, but are not limited to, the policies and procedures are based on your risk assessment and planning. It's an important point there. What you want to have is your elements and your policies and procedures based on your risk assessment and your planning. Having an 1135 waiver on file is not possible since 1135 waivers are event and geographically specific and time limited. I'll repeat that. Having an 1135 waiver on file is not possible since 1135 waivers are event and geographically specific and time limited. Next slide. Other areas for consideration in developing your policy and procedures and complying with the EP rule. Your facility's role in providing care and treatment at an alternate site. For example, what equipment and supplies will you need? Who's going to be your command and control? You can't do it 24/7, so what is your plan for backup? What staffing are you going to need? Can your staff get to the facility? What types of collaboration are needed with local officials? Do proactive planning. I can't stress that enough. Should you have a pre-designated site? Are there pre-designated roles needed? Do you have emergency credentialing procedures for providers to practice at an alternate site? For example, if the waiver does not cover provider licensure. Resources for applying for an 1135 waiver and contact information for the regional offices are listed on the next slide. Next slide. Here's the resources, and here's a website that will give you some great information of the Quality, Safety, and Oversight Group 1135 Waiver Resource website, which basically restates some of what I said, but also gives additional definitions and information. I hope this presentation has given you a broad overview of what is an 1135 waiver and how you need to integrate this knowledge into your EP rule activities. I personally want to add my thank you for all that you do it day in and day out in emergency and non-emergency situations. Now I will turn this over to Cece to cover the EP rule. Thank you all.
Thank you so much, Karen. Welcome, everyone. I just wanted to touch base briefly on the Emergency Preparedness Final Rule. So, as you all know, the Emergency Preparedness Rule published in 2016 and applies to all 17 provider and supplier types. CMS gave facilities 1 year to come into compliance from the effective date of November 2016 to November 2017, meaning that the implementation date, all facilities were expected to be in compliance by November 15th of 2017. One thing that's very important to note that the Emergency Preparedness Rule is just one condition of participation or coverage that is already required of many of you in your facilities. What we did is we have the interpretive guidelines and the survey procedures under Appendix Z, which encompasses all 17 provider and supplier types and outlines the requirements for emergency preparedness, which are also coded under E-tags. The same general enforcement procedure as is currently in place for any noncompliance found within your facilities is the same general enforcement applies here with the emergency preparedness. So going into what the emergency preparedness program entails, next slide. The 4 provisions, or what we call core elements of the emergency program, are the risk assessment, the policies and procedures, the communication plan, and the training and testing program. So that makes up the emergency preparedness program. I'm not going to spend too much time going into every single requirement, but I'm going to give a brief overview of what each of those entail. Next slide. So the emergency preparedness program is to be based on an all hazards approach. As you can see by our slide, that's our definition for what is considered an all hazards approach. Many different industries have different definitions. This is what's in our state operations manual. One thing I do want to stress is I know in the past we've focused a lot on just solely natural disasters. One thing we want to stress with the emergency planning under the emergency preparedness rule is it's not just limited to natural disasters. So facilities need to take into consideration their geographical area, but also the current environment. So we saw in 2015, 2016, we saw some ransomware attacks. We've seen an increase in active shooter situations. individual facility incidents. Those are all planning considerations to take into consideration when you're going ahead and preparing your risk assessment for your facilities. Again, per the definition, it's not just limited to the natural disasters, but can encompass anything from equipment failures in your individual facilities. As for Tracy, which we can talk about in the resources section as well, they have a lot of different materials to help you get an all hazards approach. Next slide. With the exception of the transplant program, which is part of the hospital's emergency preparedness program, if a transplant center is within a hospital, the main core element or how emergency preparedness was outlined in the final rule was based off the hospital emergency preparedness standards. It was broken down to take into consideration some of the different variations based on provider types and the patient population. So variations can include anything from long-term care and ICFIIDs having to account for missing residents. There's subsistence needs for inpatient providers. Home health agencies and hospices are required to inform officials of patients in need of evacuations. Next slide. So the 4 core provisions going into those are the risk assessment and the planning. All of the 4 core elements are required to be assessed and updated as needed on an annual basis. So the risk assessment is based on that all hazards approach I talked about. The policies and procedures are meant to help with the risk assessment and support the risk assessment. So these policies and procedures can include a range of issues, including the subsistence needs, evacuation plan, accounting for missing residents, procedures for sheltering in place, tracking of patients and staff. And again, this has to be updated on an annual basis. Next slide. Going a little bit into the policies and procedures, so these really address how patients and staff and volunteers would shelter in place, how they would evacuate. Facilities are required to have a policy and procedure for a system of medical documentation that maintains the availability of records and protects confidentiality in accordance with HIPAA. One of those important areas is also to consider what are you going to do in a facility if your system goes dark. Do you have the proper procedures in place where you can work and take care of patients, evacuate them if you don't have access to their medical charts because the systems are down? Just taking those types of things into consideration when you're developing your emergency plan. Again, staffing strategies and patient transfer agreements with other facilities. We're not being specific on what type of transfer agreements, what they should look like, whether it should be a memorandum of understanding, just having patient transfer agreements with other facilities. And then as Karen mentioned in her section of the presentation, a policy and procedure of what to do and who to request and who are your contacts for an 1135 waiver process. Next slide. The third element is that communication plan that has to comply with both federal and state laws. So it's meant to coordinate care within the facility across healthcare providers, as well as the state and local health departments, making sure you have the appropriate primary and alternate sources for communicating with those emergency officials. The training and testing program, I'll get into a little bit further, but this is for facilities to develop a training and testing program that includes initial training to staff on the policies and procedures of your emergency program. And staff need to be able to demonstrate that they're aware of what the procedures are. And Upon survey, you may want to ensure that facilities have sign-in rosters, some type of documentation to show proof to our surveyor that training was conducted. Same thing goes for the 2 exercises. Next slide. So just touching back on the communication plan, the contact information for staff, patient, physicians, volunteers, if applicable, contractors, and other facilities in the neighboring area or geographical location are important to have in your communication plan, and it is a requirement. Again, as I mentioned, the primary and alternate means for communication. A method for sharing patient information with other providers while taking into consideration no violations of HIPAA. Next slide. Then here comes the biggest area we've had the most questions on, and that's the training and testing program. So the training and testing program requires facilities to do initial training for new and existing staff, volunteers, and individuals providing services under arrangement. It's an annual requirement. Facilities have to have documentation of the training, and the training has to be specific to the staff roles, but also take into account the risk assessment. So if your risk assessment talks about evacuation, sheltering in place, make sure that the training also reflects those types of exercises that you're doing with your staff. Next slide. Then the annual exercises. So facilities by requirement are required to participate in a full-scale exercise or an individual-based exercise when a community-based exercise is not available. So one of the questions we've had is, what do we do if the emergency management officials in my state or in my local area, EMS, police, fire, cannot accommodate our full-scale exercise? So this is where the regulation gives some flexibility. As long as you're able to document that you have outreached to your emergency officials in your state, whether it's police, fire, EMS, to coordinate a full-scale exercise and it's just not available, the actual regulation allows for flexibility for the facility to go ahead and conduct an individual facility-based exercise, meaning it's specific to your facility. It should still be based on your risk assessment, but that's some flexibility if the state or the local emergency officials can't accommodate. Then facilities must also conduct a second exercise, and that's an exercise of their choice. They can go ahead and do a tabletop exercise, they can do another full-scale exercise, or a individual facility-based exercise. Another thing I want to mention is that a lot of facilities were impacted with natural disasters in the past, such as, you know, the Hurricane Harvey, Hurricane Irma, Maria, the wildfires. As long as you can document that you were affected and you activated your emergency preparedness plan, you are exempt from a full-scale exercise for that annual year per the regulation. So that's important to note, but you have to be able to go ahead and demonstrate that you were in an affected area. You still have to conduct a secondary exercise of choice. Next slide. This is standard E. This is not one of those 4 core elements, but facilities that are part of a system consisting of multiple separately certified facilities can elect to have an integrated emergency preparedness program. So that's based on your CCN numbers, and there's information on our website on how you can access your CCN number and where you can find this. As well as the integrated program does need to take into account the active participation of all of those facilities that are participating in the unified program and take into account unique circumstances such as different patient populations. Next slide. So facilities, all locations of Medicare provider or supplier must be included in the facility's emergency preparedness program. So again, all the locations operating under the same Medicare number have to go ahead and do the emergency preparedness program, taking those things into consideration that I just talked about. Next slide. So again, the emergency preparedness rule has variations based on the specific provider and supplier you are certified under. So for outpatient providers, they're not required to have policies and procedures for provision of subsistence needs. Home health agencies and hospices, as I mentioned earlier, have to inform emergency officials in their local area of patients in need of evacuation. Long-term care and your ICF-IIDs have to share information of the emergency plan with residents and family members. Another thing I want to just touch base on, based on the questions we're receiving, we had some questions related to post-action reviews or AARs that are required under training and testing. So some providers under the emergency preparedness rule are required, the facility is required to analyze the facility's response to and maintain documentation of all drills, tabletop exercises, emergency events, and revise the emergency plan as needed. There's not a specific format, again, how to do an AAR assessment, an after-action review, but some facilities that were affected by recent hurricanes conducted a review process with their emergency officials in their state or their healthcare coalitions. It's acceptable to go ahead and do that, but they have to provide written documentation that this after-action review was conducted. Another thing about the healthcare coalitions, we've encouraged facilities to link with their healthcare coalitions in their state. Our website actually has the list of different healthcare coalitions per state. Again, we're not requiring, per this rule, participation. However, healthcare coalitions by nature require certain facility types to make up the healthcare coalition, so your health departments, your EMS services, and health departments, as well as some other key players which help in the planning and also support the full-scale exercises. Next slide. I will go ahead and turn it over to, I believe it was it Shannon? Sorry, Lauren? Lauren and Nancy?
Yes, this is Lauren Reinerton, and I'd like to start the third section of our webinar, which focuses on observations and lessons learned from managing the challenges of real-world emergencies and disasters. Now, these observations grew from the dynamically changing environment with which CMS and its regional offices, survey agencies, and providers and suppliers had to face in meeting critical healthcare needs of patients and residents as emergencies and disasters unfolded. Now, disasters and emergencies take many forms, and I'm sure we have providers and suppliers participating today who have experienced one or more of the emergencies listed here. Many types of disasters occur throughout the United States and its territories every year. Hurricanes are common, and most recently, Harvey, Irma, Maria have caused massive damages, major disruptions in healthcare, injuries and deaths in areas such as Puerto Rico, the U.S. Virgin Islands, Texas, Florida, and several other states. Now, start of another hurricane season in the Atlantic that's predicted to present even more serious challenges yet again. So we also need to mention that on the other side, we have typhoons which threaten disruption of health care in Guam, American Samoa, and the Northern Mariana Islands. So the emergency preparedness rule and our outreach to providers and suppliers span a vast territory and multiple disaster and emergency types. Flooding often hits suddenly throughout the United States with devastating reoccurrence, and it appears with hurricanes, with storm surges, overflowing rivers in areas that are not able to absorb the relentless volume of water that will be accompanying some of these larger storms. And also, it might even involve dams being compromised. The wildfires have occurred in many areas of the United States, and they spread remarkably quickly. And when those forests and the environment is severely damaged, mudslides and debris slides often follow, causing injuries plus major disruptions in healthcare delivery. Tornadoes, earthquakes, and volcanoes come without much warning, and healthcare providers and suppliers can be severely affected by these emergencies. You may have damaged facilities as a result, and yet you still have to face the critical need to provide healthcare services to existing patients and the newly injured. And as Cece had mentioned earlier, there are other natural disasters. We didn't mention them all, but there are also person-made disasters and emergencies, and that can range from cyber attacks to active shooters. And the emergency preparedness rule spans all sorts of emergencies that might be facing you as a provider or supplier. Next slide, please. Challenges evolve during different phases of a disaster, and they increase related to the severity and duration of the disaster. Now, in the Northeast Division, we had Puerto Rico and the U.S. Virgin Islands under our authority and watch. Now, Puerto Rico faced back-to-back Category 4 and 5 hurricanes, and that 1-2 punch created so much damage and disruption to Puerto Rico that public health emergency declarations were established and renewed twice, spanning a 9-month period. And in the U.S. Virgin Islands, it had 3 renewals of its public health emergency declaration, and it is currently still in effect. So the duration of the disaster also has to be anticipated. Now, the Centers for Medicare and Medicaid Services works closely with state agencies and state governments, other federal agencies, both before, during, and after the disaster. And we work hard to ensure that safe and quality care is being provided. We have learned that communication and collaboration and coordination among the state and local emergency management, public health, and healthcare entities, this is an absolutely essential factor to promoting effective emergency preparedness and response. And as noted earlier, this communication and collaboration is part of the EP final rule. We've also observed that there is an additional factor that must be paid attention to by providers and suppliers. We recognize that you have great responsibilities before, during, and after a disaster in relation to your facility and your entity. But lessons learned that we have seen is that you have to also have your own individual preparedness, and it is critical because you individually have to have that foundation, so then you can then go and focus on your facilities, your staff, and also your care recipients. Next slide, please. A critical lesson of emergency preparedness is to assume nothing. In other words, be aware that in emergencies, situations change dynamically and fast, and sometimes are absolutely unanticipated. Plan A may not work, so you move quickly to Plan B, and when that does not fully work, you move to Plan C or beyond. It's also important, we've learned, to gauge the awareness and knowledge of the emergency management community with their regard to their role in emergency situations. Communication is key with emergency responders who are active, the state agencies, and also with CMS. We also found and observed that there's a critical need to get your staff ready for a full response to the emergency. And we caution you to not assume that individuals are knowledgeable or prepared simply because they've attended training. It's important that you encourage individuals to have careful attention to the training exercise, but also repeat the exercise until you as a provider feel that understanding, careful understanding, is demonstrated back. At the time that emergencies are unfolding, it's not the time to be doing a last-minute training. You really need to make sure that these drills are practiced and people are ready to control as much as they can ahead of time, and then have the energy left for the things that were unexpected. Next slide, please. Although some disasters allow time to activate plans, such as hurricanes, others have absolutely no warning. Tornadoes, for example, are characterized by a very sudden onset and immediate devastation. And we at CMS have observed that the continual readiness of providers and suppliers is essential. The robustness of the emergency plans and the readiness of those plans to be activated with fully trained staff has been found to be a key element of preparedness. Now, you also must be aware that your environment may have been already damaged from prior events, and those prior emergencies might have created an even more fragile environment which cannot really withstand additional damages. And one disaster lays the foundation for another. We saw that with the wildfires and the subsequent mudslides that occurred, and we saw that also with the 1-2 hurricane punch in the Caribbean islands. And the other issue that we have observed is that the actual geographic location of your provider or supplier, that may also affect the response to emergencies, because if you're in a remote or a very rural location, there may be a delay or a limit in the options during rescue and also recovery. And providers in those geographic locations that are at higher risk need to be aware and prepare a plan for these disruptions and challenges. Next slide, please. So opportunities that promote communication and collaboration are extremely important, and that builds a sense of community, and it also builds a more effective response to emergencies. So it's important to establish the relationships, the partnerships, and to foster that communication and collaboration with providers and suppliers, with provider organizations, the state survey agencies, CMS, emergency management, and those conversations and collaborations should be started before the disaster occurs. And as you experience a disaster, we've observed that you have to maintain situational awareness of changing conditions, anticipating actions as best you can that you need to implement or adapt as the disaster is unfolding. Now we can move to the next slide and into the lessons learned, and I'm turning it over to Captain Nancy Miller.
Thanks, Lauren. Since Lauren has already talked about all the pre-event, some of the training and other aspects, I'm going to be talking about the considerations during the continuum of during and after the event. And the length of time that an emergency extends, that's going to create continuing stress on any healthcare operations. And areas to be cognizant of include your staffing, supplies, communication with your state agencies, your CMS regional office, emergency responders, staff, patients, and others within the community. And one of the things that we've identified that happens pretty significantly in any kind of an event is some supply chain disruption. And with these events, roads and bridges are damaged, which doesn't allow the supplies to get through. And often industries and companies that are part of that supply chain can also have an impact if they're damaged. For example, as Lauren mentioned, Puerto Rico and U.S. Virgin Islands is part of Region 2 where we are, and some of the major manufacturers of saline IV fluids happens to be in Puerto Rico, and their facility was extensively damaged, and so they did not have production for several months after the hurricanes hit there in the islands. And that impacted not only the local area of Puerto Rico, but it created a national shortage of IV solutions because of the decreasing in manufacturing. So it can have a larger impact, nationally, not just in that area sometimes. There are also evolving healthcare needs during any kind of a crisis. There's going to be an immediate need for services for inpatients and outpatients. You have to consider where your patient's going to receive those services in the event that your facility is damaged. Continuing health is also a consideration. Providers and staff may have left the area. They may not be able to resume services in the initial aftermath. And there are also emergent critical care health needs such as trauma and injury rate, environmental concerns such as clean water, vector and rodent infestations. Morgue capabilities in the disaster area may be necessary also. Next slide, please. And you may be wondering, the CMS regional office and what is our role? And primarily, we're your partner in this event. And during any disruptive event, the regional office, our primary role is to help provide guidance to the affected state agencies, which also assist with the providers. And we attempt to work together regarding the healthcare providers to ensure that they can continue to meet the conditions of participation or conditions for coverage that are necessary for the facility, and the potential altered care decisions while also ensuring the health and safety of patients and residents. And this will include establishing an emergency point of contact with a backup who is in contact with CMS and the state agency. And they're responsible for promptly responding to any kind of questions and concerns that may be submitted from facilities, providers, state agencies, and healthcare providers within the jurisdiction. The regional office also ensures those communication links with affected state agencies, designated emergency points of contact within the jurisdiction. And that may require utilizing backup contingency type strategies. If the telephone and electrical power is inoperable, you may be dependent on cell phones, ham radios, even just using the internet off of batteries. Sometimes we have to go back to old school methods without the technology if we have some disruption in that. Next slide, please. And the CMS regional office also serves as a liaison to alert central office and other appropriate parties about key developments within the area. We review and respond quickly to any 1135B waivers that may be submitted for review. We refer questions and waivers or suspension of regulation requests. Those have to go to central office, and so we shift those over with that and communicate back and forth, as we said, as a liaison between central office and the state agency. And the regional office will request status reports from the state agency partners regarding what's going on in the area with healthcare providers and patients, residents, everyone that's affected will be asking for reports on those. The regional office will also assist the affected state agencies to provide their essential monitoring and enforcement activities in the event that the state agency can be overwhelmed and unable to meet their survey and certification obligations. Next slide, please. And as a provider, training and information dissemination efforts should be designed to equip individuals and organizations to be able to handle 90% of an emergency situation out of habit. And then that allows the team then to focus those energies on addressing the 10% which may be unexpected. And that's where those key elements of the training for individuals as well as groups and attention to that training that Cece mentioned and Lauren also discussed, that's where those elements come in to play. And you're also encouraged to establish open lines of communication with your local Office of Emergency Management, first responders. And you also want to try to maintain as much self-sufficiency as you can as possible in the situation with that, because services and capabilities are going to be spread thin typically during any disaster, and any kind of challenges is really going to impact everybody with that. And it's difficult to predict any kind of issues and obstacles that may arise during these emergency situations. So that's what goes back to the 90% out of habit, 10% of that unexpected is going to fall there. Next slide, please. And there may be occasions where evacuation may be necessary. It may be just moving from one part of a facility to another. It may mean geographic relocation. We did see that significantly in the U.S. Virgin Islands. We had a significant number of patients and residents who were evacuated off the islands in the event of the hurricanes. And some of those lessons learned that we've had from those is that it is essential to be able to track those evacuees because they're going to be traveling in and out and across large areas potentially, and you have to be able to track them to know where they are at any given moment in time. And that means that you have to have a stable information system. And that system has to be able to be used by multiple users at the same time. For instance, right now we're using an access database for the evacuees that are still here stateside that came from the U.S. Virgin Islands, so that the staff in the Virgin Islands, staff in Atlanta where they're taking care of them, as well as the regional office, all of us can access that database at any given time and have up-to-date current information and still be able to communicate with each other around the events that are going on and the individuals there. And with those databases, some considerations would be to use automated fields. Once they have drop-down boxes that present your standard options, that's going to save time and energy and be much more efficient than just having narrative blank entry fields with that. And it's also recommended to use consistent terminology. You want everybody speaking that same language. That will help streamline your data management and also enhance efficient report generation if everybody's on the same page with that. And it's also very, very important, because we're dealing with patients and residents, that we have to consider confidentiality issues, particularly, as I mentioned, when you're using a database that has multiple end users. Although everyone needs to have access to that information, you need to be able to mask the identity of these in the event that there is potentially a breach of that. It's very, very tempting to be able to track these individuals by name with that, but the confidentiality and HIPAA still applies even in the event of an emergency. We still have to maintain that privacy. Next slide, please. And then after the event, we're likely to see gaps in the healthcare continuum. and that can be related to the damaged facilities. They may be closed for repairs or permanently damaged if they're closed permanently. Professional staff may outflow. Puerto Rico and USVI, as I mentioned, they had a significant amount of their professional staff that left the islands in the aftermath of the storms and have not returned. So that has created somewhat of a shortage of some professional staff in that area that is being addressed. Those individuals that were previously independent and caring for themselves may now be injured, and they need supportive care, skilled nursing or home health or other care such as that may be available to them. And there are also very significant emergent mental health issues and stress that are rooted in the trauma of the event. Post-traumatic stress disorder is very, very common after large events within the population, and needs to be brought to the awareness of all caregivers in the area. Increased violence is also statistically evident with that. Depression, substance abuse, all of those have been linked to disasters in the aftermath. 1135 waivers that Karen talked about earlier, those may be necessary, and so Karen went through the full implementation of those and how to apply to those. So I'm not going to reiterate that, but just, again, to keep that on your horizon, that 1135 waivers may be necessary and are available for consideration. And then there's other numerous considerations that CMS and the state agencies can have, and which we consider those to be flexibilities in consideration of the situation. Next slide, please. And, you know, which, as I mentioned, we have flexibilities and we have waivers. And quite often we're asked, what is the difference? And there is a significant difference in many ways. And a flexibility is a policy or procedure that can be amended under the terms of the implementing statute or regulation. And CMS can amend that at will without reprogramming its system. You know, that, we can give a flexibility, for instance, for if a hospital is damaged on the 3rd floor and they want to move those patients to a previously unused part of the facility that has, you know, been reviewed and inspected to be compliant with the CMS conditions of participation, then they have that flexibility to move those certified beds from one area to another. And so that's a flexibility that we can provide locally and in conjunction with communication with the state agency as well as central office. And the waiver is a larger, more complicated piece, and that's generally thought of as a statutory requirement of the Social Security Act, and that has to be waived, and that is very formal, as Karen mentioned, you know, with the submission of the waiver, the consideration, and can be time limited based on the time of the disaster. Next slide, please. And we do have 2 of the flexibilities here. These are some of the more common flexibilities that we do have that we are seeing implemented actually currently, again, in the islands with the USVI and Puerto Rico. One of those is a special purpose renal dialysis facility. And a special purpose renal dialysis facility is a facility that is approved on a short-term basis for special rehabilitation or emergency purposes where the patients cannot otherwise be accommodated. And the special purpose renal dialysis facility can be approved to serve emergency patients. That means we have dialysis patients on an emergency basis when the approved permanent facilities closed due to a disaster, or there is possibility of having a special purpose renal dialysis facility for those in a vacation area where they may have a large number of vacationers that are coming in to the area that they just need some dialysis services in that time for a temporary time frame. And the special purpose renal dialysis facility, they have to meet all the same conditions for coverage as they normally would, with only a few exceptions. And that includes participation in network activities. They can be removed from that for a period of time. And the patient long-term care, a long-term program and the patient care plan, we do allow for some adjustments with those, with the documentation. And the period of approval for a special purpose renal dialysis facility, though, cannot exceed more than 8 calendar months in any calendar year. Those calendar months do not need to be consecutive, so you could have January, February reopen for a few months and then have to go back to a special purpose for a few months in the summer or something. It does not have to be consecutive time within that same time frame. And again, it's within any calendar year, so that in theory, if you had 4 months at the end of one calendar year and 4 months at the beginning of another calendar year, even though you have the 8 consecutive months, they cover 2 calendar years, so that would still allow some flexibilities later in that second calendar year if necessary. The same reimbursement rates actually do apply to these, as well as permanent facilities. The regional office often coordinates with the state agency and the renal dialysis network, the Kidney Emergency Response Coalition, CASER, to relocate all those patients to permanent facilities prior to the scheduled closing of the special purpose renal dialysis facility. So we want to make sure that we have that continuity of care for everyone. A temporary closure is another flexibility that we have with CMS, and that in 42 CFR 424.502, indicates that providers and suppliers are to be operational at all times. Well, as we talked about the disasters, if the facility is damaged, to the point that it cannot open, one of the concerns is, do we have to be closed permanently and have to go through the reapplication process again? And what we do allow for with CMS is a temporary closure, and that eliminates the requirement for those affected providers and suppliers to voluntarily terminate their CCN. So you do not have to terminate a CCN, do not have to go through an initial certification again. Instead, we allow for that temporary closure for a period of time, and it is to be reviewed and handled on a case-by-case basis to determine the time frame and timelines for repairs, and that works. That's where that communication and collaboration really comes into play. Most requests for temporary closures that we see, again, they will include written benchmarks about what's going on, the time frames they're looking at for those repairs, and especially what is their time frame to reopen. And of course, because it's a construction project, sometimes those timelines shift based on permits and contractors, et cetera. So again, that constant communication works back and forth to make sure that everyone is on the same page with that. And then depending on the extent of those repairs or the renovation, there may be another survey, a health survey, a life safety survey, or both may be required after those repairs are completed. And again, that will be determined on a case-by-case basis in conjunction between CMS and the state agency. And if in doubt, always contact your state agency or your regional office for any specific guidance such as that. Next slide, please. And after an event, each Medicare and Medicaid certified provider in a declared emergency area should contact your state survey agency regarding their status and their future plans. And there are times that the public health emergency may result in consequences beyond the provider's control, and some providers may never be able to reopen at their original location. However, they may be able to move to a new location and go through some minor tweaks there and just be able to transfer that practice, again, to a different location. And the ability to participate in Medicare and Medicaid then is based on the ability of the provider to demonstrate that they can furnish those services in a manner that still protects the health and safety of the beneficiaries. And when the cessation of business is due to a declared public health emergency, Waivers and flexibilities are then reviewed on a case-by-case basis to determine whether to deactivate a provider's Medicare or Medicaid provider agreement and number, or if the provider wants to go through a temporary closure, or if relocation may be necessary. And if relocation is necessary, then CMS will determine if this relocation of the current provider is under its existing Medicare certification, or if it's possibly a cessation of business at the original location and subsequent establishment of a new business at a new location, which would require another Medicare certification. Next slide, please. And in order to retain the current provider certification, the entity provider must demonstrate to the regional office that it is functioning as essentially the same provider serving the same community. And that means as a provider, they have to still be in the same state and comply with the same state licensure requirements. The provider remains the same type of Medicare provider after the relocation, and the provider maintains at least 75% of the same medical staff, nursing staff, and other employees and contracted personnel. Next slide, please. And in the event of extensive damage, use of temporary mobile facilities may be necessary. And examples of temporary facilities that we've seen used and currently being used include mobile trailers, tents, rigid form modular units, in those areas, and it's possible that a Medicare participating provider can operate a mobile facility after survey to ensure that the mobile unit complies with all hospital conditions of participation, and that includes life safety code and the provider-based rules, including remaining within 35 miles of the main provider. If the mobile unit meets these provider-based regulations, then they can use the current CCN and stay in that area, and if not, then the mobile unit will then be treated as a freestanding clinic. Again, these situations involving the mobile units are evaluated on a case-by-case basis in conjunction with the state agency and the regional office, and these facilities, because they are new, air quote, new facilities that are going in as a replacement for the permanent facilities, they will be required to undergo survey, health survey, as well as a life safety code survey to make sure that they are in compliance with that. And now I am going to turn it over to Julio, who is going to provide you with some wonderful resources for your entertainment.
Thanks, Nancy and Lauren. Good afternoon, everyone. First, I'd like to thank all the participants for participating in this great webinar as we prepare for the hurricane seasons and tornadoes, cyber attacks, flooding, and wildfires. The next few slides that I'm going to focus on is available resources for emergency preparedness. As you can see, the CMS website is a great start with obtaining information on emergency preparedness. Please take advantage of going out to review these links. It's a wealth of information. The agency is pushing transparent. We want to ensure that we have the available information and resources so our providers and suppliers can be in compliance as it relates to the emergency preparedness rule. We also work closely with our sister agency, the Assistant Secretary for Preparedness and Response, ASPR Tracy. We work closely with them when these natural disasters occur. They have a wealth of great information, so feel free to go out to their website to review the information they have as it relates to emergency preparedness. Also, as you can see, please take advantage of reviewing the State Operation Manual, Appendix Z. This is a great tool. As a former auditor, I would take advantage of making sure that my facility is in compliance as it relates to the emergency preparedness rule. It has a lot of information as it relates to the E-tags. I saw a lot of questions coming in. A lot of those answers are on our website, so feel free to go out to our website to review this information as it relates to emergency preparedness. Next slide, please. This particular slide is a wonderful course that I push that everyone please take advantage of taking this particular course. It's offered by FEMA. It's a course that relates to our healthcare providers and suppliers with training and achieving those 4 core elements with emergency preparedness as it outlines our CMS rule. It is an 8-hour course. As you can see, the logistics. It's the basic the course, and the purpose is to understand specific emergency preparedness requirements as outlined in the CMS rule and develop knowledge and skill in achieving these requirements. So please take advantage, have your staff to sit in. It is a classroom setting, so please do some research in your particular region to see if this course is available. Next slide. Okay, Quality, Safety, and Oversight EP website, our Emergency Preparedness website. Please go out here. It is a wealth of information as it relates to the 1135 waivers. I'll also talk about each natural disasters, earthquakes, tornadoes, severe weather, flooding, just a wealth of information that you can use to make sure that you are in compliance. It's a pretty easy, user-friendly website, a lot of information. As you can see, when selecting our emergency preparedness rule link on the left side, you will see general information on the regulation as well as downloads and important links. CMS will continue to update the entire website to include information which may be able to assist providers and suppliers. We also have included the link to Ask for Tracy, which can further assist providers through technical assistance. There are also our ePro, which is the Emergency Preparedness Response Operation. There's information out there also that can help during the recovery times. As we continue with our updates, if stakeholders have information or resources which may be helpful to any of these links on our page, we encourage them to contact us and provide us with these resources. The goal, I know we've been receiving a lot of questions. We would definitely take all the questions that are in the queue. We're definitely going to consolidate and try to provide as much feedback, but a lot of those answers are on our website, so please feel free to go out. Next slide, please. As I stated, QSOG, which is the Quality, Safety, and Oversight Group, Emergency Preparedness website has an area for all FAQs and resources available to our stakeholders. This is the direct link. Please feel free to go out. We also have our survey training portal module also. So I encourage all providers and suppliers to take a look at this training portal, this training module, so to make sure that you are in compliance with our emergency preparedness rules. It's a great guide I definitely will use if you're trying to do walkthrough or pilot some of the emergency preparedness. It's a great resource to be prepared as these natural disasters occur. As I close and conclude, I'd just like to reiterate what Lauren Ryanson in Region 2 stated, that communication and collaboration is very vital when these natural disasters occur. I'd like to just thank Dr. Renard Murphy, our Consortium Administrator, for giving us the opportunity to share this information across the country as we prepare, if you even prepare for these type of natural disasters. But we want to make sure when these natural disasters occur that we have all the best practice and tools in place so we can protect our provider community, beneficiaries, and also the community around that particular state. So I just want to thank you. Now we'll turn it over to Adrian Saunders as she give our closing statements.
Thank you very much. We have over 3,000 attendees on this call, and we just want to take the time to thank you for taking this time to be with us today. As everybody said, be prepared. It could happen to us. We would like for all of us to use the emergency preparedness survey process to strengthen your preparedness as a healthcare provider or supplier. A few things, a few announcements. The moderator has posted, while the training was going on, the handout so that you can download that to your system. And we're also going to have a recording available within the next couple of weeks of this webinar as well as the handout. It will be on the surveyor training website that Julio just mentioned, and you would just choose I am a provider to locate that recording. Finally, the moderator also just posted the evaluation link. We would love to hear your feedback, as we're always in a continuous improvement cycle. We would like to hear what your thoughts were. And finally, I'm going to take a minute to stop and turn it over to Cece so that we can answer a few of the questions that you've submitted via the chat box. Cece?
Thank you so much, and thank you all for the thoughtful questions you guys are sending in. So one of the questions we received is what type of information should be shared under the emergency preparedness rule and the requirements under the rule with the residents and families about the facility's emergency plan? Do we have any tips for what to communicate with the families and residents, and what specific information should be shared? So there should be a policy in place to communicate what the facilities program entails. So it doesn't need to be too specific or a complete download of your emergency plan to hand to a resident or to a family member, and we're not specifying how exactly you should document your this communication to the resident or family member. However, they should really know what the policies and procedures are and what your facility's plans are in the event of a disaster. So for instance, if you're evacuating the facility, how is the facility going to notify the family member? Does the family member have a number or a contact to contact in the event of an evacuation of their loved one? Same thing goes into, the fire drills. If your facility has to evacuate just for a fire drill for a specific time, does the resident, do the family members know where they should go? Another part of this is one of the best practices we've seen is facilities are creating these 1- to 2-page pamphlets that they're providing to their residents and family members that kind of outlines the policies and procedures and what they think is the most important aspect of the emergency preparedness plan for the facility to communicate with the family members and residents. Another question was, can facilities participate in 2 tabletop exercises to satisfy the exercise requirement? The rule is very specific. There is a requirement for all facilities to conduct a full-scale exercise. If the full-scale exercise isn't available to do an individual facility exercise, then the secondary exercise of their choice, whether that's another full-scale, another tabletop exercise, or an individual facility exercise. Another question was, is the exemption for the 1-year full-scale exercise only for facilities impacted by a natural disaster? So we can post more information online, but it is for facilities that have underwent and activated their emergency preparedness plan. So it's not just limited to specifically the natural disaster, but anytime you activate your actual emergency preparedness plans due to an emergency. So for instance, Vegas shooting, mass surges, did you activate your plan? Can you document that you activated your plan and go ahead and show that to the surveyor, and you would be exempt for that full-scale exercise, but still required to do that secondary exercise. Another question that came in was, hospitals are still asking what the expectation regarding providing training to volunteers and vendors. Can we please elaborate? So the one thing with the training for vendors, volunteers, or individuals serving under arrangement is it should be based on the policies and procedures. They should at least get some type of initial training on what your facility's emergency preparedness program is, what your policies and procedures are, and potentially even be involved in the exercises if you feel that's appropriate. What we want to make sure that happens is that facilities where they may be operating with vendors and volunteers, if there's an emergency that occurs, does the volunteer know who to contact, their responsibilities, where to go, just the basics. And another question that I'll turn over to Karen was, can we get some examples of when an 1135 waiver would be necessary? It sounds like it might be a daunting process. When explaining this to staff, I'm not sure how to demonstrate the application. Karen, can you expand a little bit on that?
Yes, first I'm going to make a comment. Since there's so many different providers on, I don't want to give specific examples, but I also want to just say for myself, don't be overwhelmed. The 1135 process has people overwhelmed or it's some big black hole. Really, you're on this call, you're beginning to understand it. It is done, as all the speakers have said who've referenced it, on a case-by-case basis, where we work with our partners to see whether you need a waiver or you need a flexibility. My presentation really was trying to stress the parameters where it can be granted. Most of my experience in the West with the fires, the floods, the hurricanes, tsunamis, is generally increases in beds or, like Nancy said, movements to a part of a hospital that's been discontinued but is still acceptable to be part of a hospital, can be used. Other examples were given where special renal facilities were allowed to participate in the program. We've also had on the West, we've had some waivers of Medicaid qualifications and Medicaid reimbursement items that we work closely with our sister division that deals with Medicaid. So I guess what I would say, and just to second what Julio said, is that you're on the call. The resources in the EP resource web links that we've given you, they have breakouts of Q&As on each particular type of provider, not necessarily related to the EP rule, but related more to the 1135 process. So I would suggest to answer this question, you first look at that, and then from there, hone your question down, and you can either work with your state survey agency, or you can send the question into the list that I had in my slide about the RO address, the email address. And I know that the people on this call, we will get back to you. We're all from all across the country in CMS to help you through the process. So I think with that, I'm going to turn it over to Lauren. Or Cece, you're going to say the question, and Lauren's going to respond.
Yeah, I can read the question real quick. So the question was, is the regional office role only applicable in designated emergencies, or are they available for questions guidance in the more limited localized emergency situations? Lauren? Lauren, are you still there? Okay, so just to go ahead and answer that, the CMS regional office is available for both designated emergencies as well as more limited localized emergency situations. Your regional offices work in conjunction with the state survey agencies. Provider and supplier communication with the state agency regarding localized emergency situations is critical. Providers and suppliers can reach out to their regional offices for guidance related to continuing compliance with Medicare requirements during challenging situations at any time. So I hope that answers that question. And then I can turn it back over to the moderator to wrap up the call, and we will post the questions we are receiving. Just to clarify this, we're posting the questions we're receiving on the surveyor training website as well, along with the recording as was stated. Another question that came in was, does this webinar account for the training requirement for the emergency preparedness rule. The short answer for that is no, it does not count. This webinar was solely informational and to provide additional resources, assistance, and clarity on the topics we provided. And we thank you all for all the continued work you all do and making sure that your beneficiaries and the public is taken care of. Thank you.
And Cece, I'm going to pick up before the moderator comes back on. This is Adrienne. Again, as Cece mentioned, we're taking all the questions that you have posted in the chat, and we will post the facts document. And we want you to also know that you can submit additional questions on the evaluation link that the moderator has posted. We have a space to get questions from you there. And finally, I would just like to thank this EP work group, which consisted of Cece Blondeau, who is our special assistant with QSOG out of our central office in the Baltimore area, Karen Fuller, who's a branch manager out of our San Francisco office in the Western Division, Julio Griffin, who's a branch manager out of our Atlanta regional office, Captain Gregory Han out of our Chicago office in the Midwest Division, Shannon Hills Klein, who's a branch manager out of our Dallas regional office, Captain Nancy Miller, who's a branch manager out of our New York office in the Northeast Division, as well as Lauren Reinerston, who's an ARA, an Associate Regional Administrator out of our Northeast Division, the New York office, and Adrienne Saunders, myself, who's out of the Atlanta Regional office. We'd like to say a special thanks to Sandra Pace, who is our Associate Consortium Administrator for the 1135 waiver material, as well as we would like to thank Danielle, who's been our moderator today, for assisting with this webinar. Danielle, I'm turning it over to you.
Thank you, Adrienne, and thank you all for joining today's conference call. We'd like to thank you for your patience, and thank you for joining. Until next time, you may all disconnect and have a very wonderful day. Thank you.
All right. Next is